So now hopefully you can see all of our panelists, Dr. Jakasic, Dr. Allender, and Dr. Spring. And we're going to start with a conversation amongst us, and then we'll open it up to some of your questions. So thank you for sending those in. And Dr. Allender, let's start with you. And so you sort of described the approach that you're taking to doing obesity prevention using a systems approach. And in your work with communities, can you talk to us a little bit about how they perceive that approach as compared to more traditional obesity prevention models, and what seem to be some of the key challenges?
Thank you for that. So as a follow-up to the Lancet Obesity Commission, we have a paper in Obesity Reviews that addresses exactly that question. How is this different to usual practice? And the basic response is that it makes more sense from the community's point of view. So we don't go in and do a 3-hour, we used to, but we don't anymore do a 3-hour lecture on what is systems and why not the way things are done. We take an experiential approach where we say, we've got a way of thinking about this problem that might be helpful. Would you like to try that? And what we find is, so we de-risk the social capital loss of doing something as a community leader that the rest of the community thinks is silly or doesn't like. And so we'll run the first session, which is a group model building session to understand the complexity, and then ask, is this something you'd like to continue with? And the community gets really, really excited because it allows them to visibly see how they understand the problem, share how they see the complexity, and begin speaking a language of systems, complexity, interaction, delays and feedbacks and unintended consequences in a way they haven't been able to before, but has been there constantly. And so sectors of the community that know they should work together begin finding ways to work together in a way that's evidence-informed and in a way that responds and respects the complexity that they're usually fighting against, but our traditional methods can't handle.
Thank you. And Dr. Spring, I'd like to pick up where you left off, which was talking about there's been a lot of positive momentum around moving the diabetes prevention program into the YMCAs, but there are challenges around recruitment and retention, particularly for Black and Brown populations. So can you talk a little bit about, what you see as some of the solutions there, and what are things you hope to do going forward?
So I think one of the things it's taken us a long time to recognize is that although we may live in our offices in healthcare settings, the people that we may want most to reach don't live there with us. They live all over the place. In a city like Chicago, they're in many different arenas. The folks who are treating them in the hospital may not know the resources that are there, and they don't have infinite time or resources to come in person for treatment. I think actually I thank COVID for one thing it's introduced us to, which is how much it's possible to do remotely. And I think this has been the major barrier for getting underserved community members involved in obesity treatment. There have recently been some studies using online and asynchronous internet communication to deliver the DPP, and they have worked really well with federally qualified health centers. So I think we just need to move in this direction. And even, people are often afraid of technology being a downside for underserved communities. I think we have seen some of that with trying to provide education via the internet. But I think what we can count on is that there's a reverse digital divide for access to mobile tools. So African American and Hispanic communities in particular have made very extensive use of mobile health tools. And I think that's just a great way to outreach, even for older people who we're starting to work with now. Even though we're afraid they may not be able to use these tools, if we spend time with them, and if there is warm tech support at the other end of the phone when they outreach for help, they can do fine.
Mm-hmm. Thank you, Dr. Spring. Dr. Jakasic, I saw you nodding. Did you want to react to that at all?
No, I completely agree. I think, COVID's been a curse, but it's been not a blessing by any means. But I think we've learned a lot about this. And, I think there's some data out there, and Bonnie, you probably know this better than I, but somewhere I read that it's something like 70% of older adults in particular are desire to actually have health delivered remotely and are willing to do that by telephone, by your telephone, not even on a computer, like a mobile system. And a similar number is also in number of underserved communities where individuals actually do have access to these phones. And so I think there's a desire for individuals to get this because of the convenience and the touch points that we can have with them as well. So I would agree with Bonnie completely.
And let's stay with you for a second, Dr. Jakasic. One of the things that you taught us in your presentation is, on one hand, physical activity is pretty straightforward, but on the other, people can view it very, very differently. And so then taking all those different individual perspectives and trying to apply a system science lens can be hard. And so can you talk us through some of the challenges of trying to reconcile those two things?
Yeah, I think that the one thing I think we have to keep in mind is some people think about physical activity as physical activity, moving around, lack of sedentary behavior. Others, when they hear that, their mind immediately turns to what they perceive to be exercise and what a lot of people perceive to be exercise. And that sometimes can be a barrier for them for a variety of reasons. And so as we start to think about the systems and policies, it's wonderful if we say, bike lanes are great and we can actually, that's great. However, there are a number of people who cannot afford to have a bike, who don't. In Pittsburgh, we have a lot of hills. Their fitness doesn't allow them to pedal a bike up the hill. So I think that as we start to think about this, we have to understand there's a lot of perceptions that go into this as well. And I think we have to give it a broad scope if we're going to touch the masses in many ways. That's my perspective.
That's great. And one of the things that might be helpful is thinking about, well, how do we engage the private sector into realizing some of the opportunities when it comes to obesity prevention? And so maybe Dr. Allender, if we could start with you, are there examples from your community-based work where you've been able to effectively engage the business community, and how has that worked out?
Thanks. There's two ways, really. One is beginning with them as a part of trial design. And so we have several supermarket trials where supermarkets have been prepared to change the way that they present food, the way that they sell food, the way that they price food. We use an adaptive trial methodology using AI for that to get answers very quickly, and they've proven very effective in changing sales patterns in communities. And then the other way is with the process I just showed you, is to invite business owners and leaders as a part of the community to respond. And we find that they're ready, willing, and very able. And the question is just, how do you fit into this solution and what's possible from your point of view? I'd say it's an incredibly powerful part of the community that we often overlook and shouldn't.
How about you, Dr. Spring? Have you done business?
I would point out that workplaces are also a kind of a community, and there has been a fair amount of engagement in these kind of obesity interventions in large work sites. So, for example, the American Heart Association has a group called the CEO Roundtable, where the CEOs all got together and realized that if they don't do something about this problem soon, they're going to be paying a great deal of money once people have diabetes because the care costs increase. So that's one place I've seen it. The other place that I think is very interesting is that there's tremendous interest in commercializing these kinds of interventions. So those of us who do this sort of work have been just inundated by people that want to market what we do. So clearly there is some sort of a value proposition there that businesses see. It's here we get into some of these bicultural issues. It's not easy for an academic to play in that space effectively, but it's another form of cross dialogue that I think we benefit from.
So I'd like to pitch a last question to all of you, starting with Dr. Jakasic, because you've all mentioned different types of community engagement with a little c. And I'd like to hear for each of you, with your researcher hat on, how those engagements with community have influenced your priorities as a researcher and maybe shifted the way you choose to ask specific questions or design specific studies. And Dr. Jakasic, let's start with you.
Yeah, I'll keep it brief. One thing that we did going into the community is before we jumped in and said, boy, let's go in and do these things. Our university, as well as our own team, took an approach of let's do the needs analysis within the community. We think we know what we want to give them. And what we found was that it's particularly in these underserved communities that the two things that popped were obesity and diabetes. What's interesting to me about that, though, is they didn't say physical activity and food access. They were telling us about the disease state. And so that's helped us to kind of think about how do we actually have to not just message to them, but now engage with them in terms of meeting their needs. It tells us what do we need to be bringing to them? And through that process, they also identified the individuals in their community who they perceived to be kind of core leaders in this space. And we needed to make sure that we were not kind of pushing them to the side, but rather partnering with the individuals that they had a lot of respect for. So before we went in and did a real research project, we needed to learn how to interact with that community in a way that it would be engaging so that we now could learn more from them. And so that was the one big lesson that we've learned, and it's been a really rewarding experience taking that approach.
And Dr. Spring, how about you? Lessons learned from your community engagement?
The most important ones, there are two. One is, has already been mentioned, it's humility. The other is the absolute necessity of trust, and that is not something that's built overnight. It's not a matter of just bringing people things, tools. It's a matter of building relationships so that they know that you understand their needs, that you empathize, and it's not a sort of a simple process, but it's a critical one.
Thank you. And Dr. Allender will give you the final word.
Thank you. I would echo all of those things. And I think we have to shift our role to understanding that our job is to provide the tools and the opportunities for the communities to solve the problems in the best way that makes sense for them, by them. I think that's where we need to start and end.
Thank you, Dr. Allender, Dr. Spring, and Dr. Jakasik, and everyone in the audience for your very thoughtful questions. And now we're going to turn to Nico Pronk and Chris Economos, who are going to close out our workshop.